Okay. Thank you. So I think it's either a testament to the high quality of the talks that we had or to how early the symposium started, that the room is much fuller now at the end of the lectures than it was at the beginning of the lectures. But I think it's the first thing, because these were really great talks. And one more quick round of applause for all the speakers here. Really thoughtful presentations. Now, for those of you who are who've been logged in and following the sort of the question stream, we've gotten many questions over the course of over this symposium, directed at basically all of the speakers, and I have the opportunity to see which ones sort of garnered the most thumbs up, so that the ones that I think the audience are most interested in. So I think we'll start with those because they're pressing from your standpoint, and then I'll pick through some of the other questions in the remaining time that we have. We have about a half hour, and we'll cover everything that we can. I'm apologizing ahead of time. We don't have time to answer all the questions that were asked. So the first question that that generated the most interest I think goes back to the first talk of the day, is which patients with AL amyloidosis should not be considered for upfront transplant? What?
So again, I think that I would need this microphone, please, because I just fell off.
Yep.
Yes. So again, I think the eligibility criteria for stem cell transplantation in patients with multisystem AL amyloidosis vary from center to center and the experience of the centers. At my institution, newly diagnosed patients with AL amyloidosis without prior treatment who come to BU amyloidosis center, the 20 to 25, maybe 30% of patients are eligible to get stem cell transplant. So majority of the patients are not eligible to receive stem cell transplant. So again, it is not for everyone. Patients with significant heart involvement, poor functional status, systolic blood pressures less than 90 are definitely not eligible to receive stem cell transplant. And this is really in a highly selected patient population. Furthermore, with advent of new therapies and novel agents, I think that if the patient is borderline for stem cell transplant eligible, then I think we would rather err on the side of doing non-stem cell transplant regimen first and offer stem cell transplant when organs have recovered better or if they've not achieved a response.
Can I ask a follow-up question to that maybe to both of you or anyone else on the podium? For patients with an 11-14 translocation who have not responded adequately to first therapy, or whatever that is, not non-transplant therapy, do you stretch or change or do anything, do any other considerations with regards to transplant eligibility for that patient subset?
So we do have a subset of patients when patients were treated with CyBorD in the community for 11-14 translocation and did not respond after 3 or 4 cycles, and then they are sent to us. If they are eligible from other perspective, we would offer them stem cell transplant or at least a melphalan-based treatment.
Yeah, I would say it's also a matter how high the DFLC is. So is there another attempt possible to lower down to get a response before transplant? So if there's a reasonable way to do it, we would also offer these to the patient, like lenalidomide or now DARA.
One question that came up in the stream, again, for any of the transplant physicians here, how do you select dose, melphalan dose for your patients? How do you decide when a patient isn't suitable to get 200 milligrams per meter squared?
So historically, we have been using a risk-adapted melphalan dosing system where patients are getting MEL 200 if they're over sick, if they are based on advanced age renal involvement and cardiac involvement. So anybody who is over 70 or has a EGFR less than 50 or cardiac involvement stage 2 or greater is reduced to MEL 140. Now we have an exciting clinical trial where we're using PK-directed melphalan-based dosing, where we give a test dose and we target an AUC based on Australian data of 13.5. So we do really personalized melphalan dosing, and we've included about 10 amyloid patients in that cohort, where we don't necessarily reduce the dose based on the patient's clinical characteristics, but we use their AUCs to guide PK dosing.
I could see how that would be useful for reducing the dosing in renal insufficiency patients, right? But patients who you're reducing the dose for because of their frailty, should we still be shooting for the same AUC, or should we?
We don't know. That's why we're doing the trial.
Mm-hmm. Does anyone?
But I can tell you that the patients who achieve that AUC that has been shown by the Australians to be really the quote-unquote sweet spot have done quite well.
Anybody
And
else?
probably frailty are not the patients who are being selected for stem cell transplant.
Does anyone else have any comments on that topic?
Yeah, I do want to congratulate Heather and Vishali and others who put together their experience with patients transplanted with MEL 140. It's an interesting option that may be of some use in patients who achieve good responses to CyBorD after 4 or 6 cycles. I don't think we've taken enough of the myeloma experience to heart. The myeloma experience is induction, show responsiveness. In the modern era, it's optimal response, and transplant. And I do think there are many patients who'd be spared the recurrence of disease at 2 years, 3 years, 4 years after CyBorD had they been consolidated with transplant. And MEL 140 is extraordinarily well tolerated and almost as good as MEL 200 in many instances.
Something that we didn't really touch upon at all today, but which I think is a common scenario, is our treatment strategy with regards to induction therapy and or stem cell transplant different for patients with IgM AL amyloidosis?
It's a difficult one, I think. It's very rare, but and it's a problem to treat these patients to really achieve a remission without a stem cell transplant. So the pressure to treat these patients with a stem cell transplant is higher actually than the normal AL patients. So that would be my comment to this.
So IgM-associated AL amyloidosis has been reported by multiple groups, including our groups from UK, from Mayo Clinic. The most recent publication was from the Mayo Clinic group. I don't know if Surbi is in the audience or not, but she was the first author on the paper. And they divided IgM-associated amyloidosis into 2 categories of lymphoplasmacytic lymphoma, so like Waldenstrom's-associated AL, versus pure plasma cell neoplasm-associated AL. And again, I think what was really different in this paper was that patients who had LPL-associated or lymphoplasmacytic lymphoma-associated AL did receive treatment which was similar to Waldenstrom macroglobulinemia-like treatments, like Rituxan, bendamustine, and other treatments. Whereas patients who had pure plasma cell neoplasm-associated IgM AL amyloidosis were treated more as AL amyloidosis. So we, generally speaking, at my institution, do transplant these patients. And actually, in our cohort of patients, they have done remarkably well, even better than AL amyloidosis, with the relapses are really, really low or that we've not really actually seen any relapses.
Yeah, I think the message has gotten through to the Waldenstrom's community too. If a patient is diagnosed with Waldenstrom's and has AL, it is worth considering stem cell transplant as part of that induction therapy. Many Waldenstrom's patients, after all, 10 to 15% develop AL. Many of them develop later in the course of disease after they've been rather heavily treated, and it's complicated to offer stem cell transplant in that circumstance. But early on, stem cell transplant can provide a significant benefit. I totally agree with Vishali. The responses are really dramatic and quite durable.
We have a few questions focusing on cardiac issues. One, I think, is a very common one. Can you comment on the relative value of and use of NT-proBNP versus BNP in terms of tracking patients, pros and cons of each marker?
Obviously, the biggest issue is that some centers have one versus the other. So there's not a formula where you can completely where you can change from one to another. So I think really it's following the baseline with whatever technique you have, and labs can argue about why one versus another, but whatever one you have, following that one serially. And I think as Heather showed with her patient, or when you're looking at BNP or NT-proBNP, you do want to look at the overall trend, because you can get spikes very easily. If somebody goes into atrial fibrillation with rapid ventricular response, NT-proBNP can skyrocket, and doesn't mean that the heart got worse. If you look at the trend over time, that's the most effective. Important to recognize, despite the fact that there are the criteria for organ response, is that it is known that BNP, NT-proBNP both can vary about 40% over a week in a patient who is completely clinically stable with just general heart failure. So I try to explain to the patients that we're really looking at the baseline and we're looking at the trends. And as we all know, our patients who plot things and they want to know if they're getting better, that's very difficult until you have the longer term follow-up, as Heather showed us. I think you really are limited to using the one that you have in your center.
Another cardiac question that came up, it's actually kind of two related questions, particularly in the United States, where cardiac ATTR dominates more, I think, than over neuropathic types due to the predominance of wild type and also the L122 isoleucine subtype. Because a significant subset of those patients will have MGUS as they get older. 5 to 10% of patients, right, in their late 70s and early 80s will have evidence of a monoclonal gammopathy. According to the algorithm that we discussed, where you do blood testing to make sure that you can trust the results of the PYP scan. How do you trust those results of the PYP scan in terms of differentiating between AL and ATTR? And is that a patient subset, who has to have a cardiac biopsy to distinguish? And as a second question, are there can you talk about other situations where cardiac biopsy actually probably needs to be done to make the diagnosis?
Yeah, so great question. And for those in the audience who might not know, for especially wild type TTR, the yield of non-cardiac biopsy is relatively low. Fat aspirin is about 15%, but it is 15%. So if you have an experienced center with good fat aspirin, you should do it. If you add on a bone marrow, you'll get up to 35%. You'll get a little bit more. Heart biopsies, are not benign procedures. So although the overall risk is relatively low, there are potentially serious complications. Most serious one, of course, is death due to perforation. That's pretty rare, but it does happen, or a need for emergency cardiac surgery, or disruption of the tricuspid valve, leading to severe tricuspid regurgitation. So that's one of our challenges. True amyloid patients are at less risk because the right ventricular wall is usually thick. so a little less chance of perforation. But especially, of course, when we didn't have treatment, just to diagnose the disease for academic reason, not as important. But back to the MGUS. So in the studies of patients who were diagnosed with wild-type TTR during the era where biopsy was required, 30 to 40% of those had an MGUS. But of course, they were selected patients who were getting tested. So it is a high percentage. What we're preaching to the cardiologist is they really need to do the serum-free light chains, the serum and urine immunofixation, and they need to work closely with the hematologist. And really, you are going to use other factors. So you're not going to biopsy every single person that has a slight abnormality of free light chains. But if they truly have a monoclonal protein, you cannot use the PYP scan alone. So you decide who needs a cardiac biopsy. Now, if you have a 90-year-old patient, bilateral carpal tunnel, spinal stenosis, every single thing, maybe there's a little monoclonal protein, but you still really feel that it's TTR, you might not biopsy them, but most of the ones that are not in that category. So one trick that I've used with these wild-type patients, I look for any tissue that they had anywhere. So did you have a prostate? Oh yeah, guess what? 4 years ago, TTR in the prostate. Bladder is pretty high yield. Spinal stenosis, I put that in to be provocative. Now that was 45% wild type, not 100, but we don't know what it's gonna be, but it's, or the patient comes to you, they have active carpal tunnel. Then you can send them to the hand surgeon and say, take some of that tissue and get it for me. So I do think heart biopsy definitely still has a role. You want to make, not all centers actually are adept at doing heart biopsies. So if you're outside of a heart transplant center, they're not done as well. So you may make sure you get somebody good and biopsy them. But if they really have a monoclonal protein, you cannot use a PYP.
Yeah, I think Martha's 100% right on most things. We're a little more biased towards heart biopsy in patients that come to us who are symptomatic and perhaps had not had a good experience with a beta blocker and have a positive PYP scan and have an IgA lambda in serum immunofixation and lambda light chains of 50 or 60. We don't routinely recommend cardiac biopsies if we think we can get away with a fat pad, but in many instances the fat pad's negative. So we try to serially track things, simultaneously track things as opposed to doing them serially. So we'll send off the TTR gene test. We'll arrange for the heart biopsy. We'll do the fat pad aspirate. If the fat pad aspirate is positive, you really have to know how much amyloid is there, because it may be untypable because there's too little amyloid there. We do go back over prior biopsies that may have been obtained in the patient. You can't, of the 60 or so cases, and Dr. Gadara knows more about this than I do, who had amyloid in their ligamentum flavum, there was somewhere around 10%, 15% that had amyloid of indeterminate type. So even the ligamentum flavum, when it has amyloid isn't 100% useful. So we take all of those factors into consideration, but we have a low threshold as a rule to obtain a heart biopsy if we need to know what to do for the patient in a timely way. Typing can take 2 weeks, and it's often a struggle. And you want to be able to have some certainty with the typing, but typing is not 100%, depending on the amount of amyloid that's present in the tissue that's offered.
We really do agree. Just
Yes.
just to clarify, actually, in our case, we get fat aspirate the day before I see the patient. I'm going to have it at 12 o'clock that day. And so I can decide, do I want to do a heart biopsy that afternoon? So it's done very, very quickly. It's pretty low yield in the wild type. But if you have it and you get AL from there, you might save the patient a heart biopsy. But again, we preach to the cardiologists that The consideration of amyloidosis is a medical emergency because you do not know if it's TTR or AL, and guessing is not good. And we didn't touch on the fact that there are patients that can have more than one type of amyloid, all these exceptions to the rule. So the more that you see, the more you get paranoid about that maybe this patient is the exception. So we tell cardiologists that they have, I made this rule, no data, but you have 1 week to get all your tests. Now, you might not have the typing, but you need to get all your tests. So that would include, if you're going to do a biopsy, this does not stretch out over 18 months. This has to be fast. And I'm sure that many of you, if everything is consistent with AL, you often may consider that you're going to treat the patient before you get the final typing result. So we certainly have done that. So the problem has been that for cardiologists, this has been either a fatal disease or an academic disease. Now they really, truly, our sessions are completely packed with people wanting to learn about it, but they're getting very, very confused about the screening for AL, and we recognize that many hematologists who are not amyloid experts are often confused about it too, so.
The next question has to do with stem cell mobilization. And I was wondering if anybody on the podium could speak to the potential complications that occur in amyloidosis patients during mobilization, and whether patients with advanced cardiac amyloidosis are handled differently during that period.
I could say I learned from my mentor to the left of me, Dr. Comenzo, that patients with either autonomic dysfunction or advanced cardiac disease really have difficult times with fluid shifts, hypotension, arrhythmias, and any patients with those characteristics are mobilized in the hospital on telemetry. We don't use cytoxin mobilization. We use G and plerixafor for all of our patients. And I usually use it as a stress test, actually. So patients who have a difficult time with their mobilization will have a very difficult time with their transplant, and it may be a useful consideration to think about alternative strategies if they really have a hard time during their stem cell mobilization. Patients who you think may have a hard time during their stem cell mobilization, but then prove you totally wrong, and really their hospitalization is boring and without any blood pressure, fluid retention issues, usually predict for a very much easier than expected transplant course.
We also use that term, I mean, from a cardiac perspective, it really is a stress test, so I think you want to be cautious. You know, obviously, if you're going to be harvesting, it's because you think the patient is a potential candidate, but they do declare themselves. We try to follow the patients very closely around that time with a nurse practitioner who's very used to the fluid shifts that may occur, the arrhythmias, try to manage these things early. But when we see that, we know that's a red flag. Now, sometimes patients later on may improve, and later on they may go on to have their stem cell. But the other thing I'll say about stem cell in general, you asked that question in the beginning, is that although I think the criteria may vary a little bit, we know that NT-proBNP of greater than 5,000, the troponin greater than 0.06, the blood pressure less than 90, pretty standard criteria. There are a subset of patients that are within that threshold who are sicker than they seem to be. So again, numbers are great, but they're not everything for a variety of reasons. And so if you see a patient that's struggling or has heart failure out of proportion to their biomarkers, those are really red flags.
Can I just ask a question and follow up? Why G plus plerixafor for all patients? I mean, as opposed to just G? Is there a difference? Does it permit a difference in dosing, or?
It just minimizes the time to. I mean, it's just very effective at minimizing the need for multiple apheresis sessions.
you-
And also, I think the dose of G is lower when it is used with
Yes.
plerixafor at 10 mics per kilogram versus when it is G alone, which is 16 mics per kilogram. So I think the fluid retention properties and capillary leak associated with high doses of G is lower. So at BU, for all cardiac involvement patients, we use G plus plerixafor mobilization, whereas for stage 1 cardiacs or renal only, we use GCSF alone. And we use plerixafor also on demand for those patients, not as planned. Also, one other thing about the MGUS and wild-type TTR, which we were talking about earlier, as Jeff is scrolling down all the questions, is that in our series, there were 39% of patients with wild-type TTR who had monoclonal gammopathy of unknown significance, and majority of them were biopsy-proven. Of those 39% of patients, 95% had IgG kappa or kappa. So when you have a lambda monoclonal gammopathy, always be careful because then you might be dealing with AL and not wild-type TTR. Furthermore, V122I ATTR mutant amyloidosis, which is common in African American patients, they have a higher risk of MGUS. And in our series, there were 50% of patients with V122I who had monoclonal gammopathy of unknown significance. So again, I think nuances of this disease are such that experience is absolutely critical. And I think if there are any questions about diagnosis, do not start them on treatment. Please refer them to experienced centers.
To tafamidis, you mean, or on TTR treatment. I do think we will probably be seeing more heart biopsies. So heart biopsy has been usually done post-transplant for rejection for certain types of myocarditis, although really mostly if we think there's giant cell, it's had a lower role in recent years. So I actually think you will see more heart biopsies, which is not necessarily a bad thing. A quick question I have for the panel, because I've been shocked at this issue that I found out from my colleagues, that they order serum protein electrophoresis with immunofixation. That's what they put on their order at their institution. But then they only get it, immunofixation, if the SPEP is abnormal. So I did not realize that that was very common, but it is common. So it's common at fairly major medical centers. I think those of us who are at amyloid centers are so spoiled, we do not know this. So this is a huge problem because the doctors read the consensus statement and it says you need to exclude a monoclonal protein. Okay, we can agree they really should do urine, but we really want them to do the serum, right? So they do the serum-free light chains and they order everything that we tell them to order and they get a result back that says no monoclonal protein. So, they think that they're done. Again, most of the time the light chains would have bailed them out, but not always. But I've just heard from one of my former trainees who's at a pretty major medical center that he just had to fight with the lab director just this week, so that when he orders it, he'll really get it. So I don't know, but I figure you're all here at ASH and you must have relationships with lab directors and do something, but it's actually not a minor problem for cardiologists.
Okay.
I think you're absolutely right. I've been very fortunate to be able to order them both and get them both, and we do that routinely at Tufts in large measure because B.J. Magnani moved there in 2008 and has a real interest in the plasma cell diseases. But there are pathology services that view the immunofixes as labor intensive. The labor component is not small, and therefore they don't do them routinely or reflexively if the SPEP is negative. I am hopeful over time as mass spec, which is I think going to be beta tested next year by the binding site, as mass spec comes into the arena of clinical laboratory tests, it will take off because it's less labor intensive in the laboratory and provides you with quantitation. And that may indeed be the only solution to this problem because the older clinical pathologists are sticking to CAP guidelines which call for reflexive testing.
What we see is a patient has 2 or 3 echoes, maybe 2 or 3 heart caths, and then finally we get this simple test that could have led us to the diagnosis.
think we have time for one more question, and then we're going to wrap it up. Before we go over this question, I just want to remind everybody to do the evaluations for the program. Turn them in. They're necessary to get your CME credit. Please, please, please do the evaluations. Plus, if we do this again in the future, we want to know what we did right today, and we want to know what we did not do right today, and that's important feedback for us. Last question. Vaishali. I'm going to start with you, but this is really a question for everybody at the table. During your talk, you mentioned data about patient attrition during bortezomib induction, which reminded me of old data you generated using melphalan before, when what we had as an induction option was melphalan and prednisone before moving to transplant, and the data actually seemed the same in a way, that we lost some patients. Patients who started as potentially transplant eligible became ineligible over the period of time that they were getting induction. So the two topics I want to sort of finish with are, one, those patients that we lose or who slide out of transplantability, is it, in your experience, mostly due to induction toxicity, or is it mostly due to progression of amyloidosis or a complication of amyloidosis while we're waiting to get to transplant? That's A. And then the second question I have is, so when using induction therapy in a transplantable patient, in your own practice, do you simply use it until you get the patient to transplant as fast as possible, or do you use it for a prescribed period of time, a certain number of cycles, and with the plan to move to transplant like we do in multiple myeloma? I'm going to open it up to everybody.
So I think, induction therapy can be considered as a stress test too. If you cannot handle induction therapy, it is unlikely that you're going to be handled stem cell transplant. Furthermore, I think all the trials that I did mention in my talk, which was one of our trials, HOVON trial, as well as the Chinese trial, the bortezomib was given as twice a week. So again, with Cyborg-D or once a week, maybe the results might be different for patient attrition during induction therapy. At my institution, we do offer induction therapy for patients who have plasmacytosis of greater than 20%. Those patients do get induction therapy once a week, bortezomib, Cyborg-D, and for a limited number of cycles, whether 3 or 4 cycles, followed by stem cell transplant. If patients do achieve a complete hematologic response after 4 cycles of Cyborg-D or 2 cycles of Cyborg-D, I generally do not perform stem cell transplant, as I have said it very kind of crudely, that I don't want to kill anybody in hematologic CR during stem cell transplant. But that's my viewpoint.
So our cutoff is 50 milligram per liter DFLC. So below that, we also offer direct transplant, and then we do the myelinization with cyclophosphamide, also to have a chemo stress before. And the other way around, if you have a patient with 200 milligrams of a DFLC, we want to see this patient after 1 or 2 cycles. And then we can see what is the toxicity and what is the likelihood of remission, and then we make this the decision how fast we go to transplant. So that's our approach.
So this is funny. We use a cutoff of 10% plasma cells in the marrow. Patients who have more than 10% plasma cells in the marrow, at diagnosis, we score as multiple myeloma. We code them as myeloma because the pathologists at our institution are kind enough to put in the report consistent with multiple myeloma, which solves the insurance issues. In patients who are significantly sick, stage 3 cardiac patients, for example, we treat them with daratumumab, Velcade, and Dex. We get approval for daratumumab, Velcade, melphalan, and prednisone, and treat them with daratumumab, Velcade, and Dex to get them cytoreduced as quickly as possible. At the same time, in patients who may be transplant eligible, we start treating them with weekly Cyborg-D and seek insurance approval. So they may get 1 or 2 doses of Cyborg-D before they get mobilized and transplanted. I think in the literature on amyloid, it can become very confusing. The issue of induction therapy, the issue of outcome with transplant, the important issue which hasn't been raised here effectively, I think, is consolidation after transplant. We really believe that patients who have any persistent clonal disease after transplant should be consolidated. There is no maintenance therapy that's been approved for AL. Dr. Landau has a trial using Exazimib for 2 years. But I do think if there's persistent clonal disease post-transplant, an effort should be made to consolidate patients. And if the patient can tolerate an IMiD in the setting of consolidation, I have no problem using an IMiD in that setting. So there's a lot of customized therapy. Where's it going to get us? Well, I do think we should come to some agreement as to when we're going to assess response. The logical thing is to try and assess response at a time point, at a year, as opposed to saying post-stem cell transplant. So we try to customize things for individual patients using all of the semantic hocus pocus that we can muster.
The last word.
I think then that that wraps up today's session. Thank you all for those of you who stuck around for the entire thing. Please feel free to come up and talk with us for a few minutes after if you'd like. Thank you again so much for everybody. Thanks to all the speakers.